right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I'm joined by a father-daughter duo for a very special episode, Dr. Matt Werd and soon-to-be Dr. Maddy Werd. Thank you guys for joining us.
Thanks for having us.
Better.
Absolutely. So, Dr. Werd, you are in Florida, and why don't you kind of tell the people who don't know kind of your background of what you specialize in and what you find interesting about the field of podiatry?
Yeah, great question. So I'll be, as of I think next week, 30 years in practice. Hard to believe.
Wow. Congratulations.
Thank you. Grew up in the Midwest, Chicago.
Mm-hmm.
Undergrad at Indiana. I went to Shoal when it was downtown Chicago.
Mm-hmm.
Always interested in sports, being somewhat of an athlete myself, which is kind of what brought me into it. And I ended up doing a residency in Miami, Florida. Kind of took a leap to go outside the box when I had some Chicago
That's not
opportunities.
much of a leap. That's not a big... Taking a leap is going to like North Dakota or like Northern
True.
Canada. That's a leap. People don't take a leap to go to Miami. They are excited to go to Miami.
Well, so, you start residency in July, and growing up in the Midwest my whole life, I graduated podiatry. Next week, we got married. My wife and I drove to Miami. And it took my wife about a year to stop perspiring being in Miami. Anyway, Dr. Kashik was my residency director and mentor, really big into sports medicine. He took care of the Miami Dolphins, Miami Hurricanes, all of the Miami Ballet, really well-trained. He did the Kern program when it was Kern in the day. Mm-hmm. Well-trained surgically, a lot of sports medicine, and I really had some opportunities at the time. I didn't realize, how special that was. And originally I had plans to go back to Chicago and had a nice opportunity to stay in Florida. And he encouraged me to be where I am today. And I started from day one, 30 patients, 25, 30 patients my first day in practice that was already well established. Mm-hmm. And I've been at the same practice since then. So it's really been a nice opportunity, and all three of my kids have grown up here, and they've all done well, as you'll hear from Maddy.
Yeah, absolutely. So sports medicine is one of those kind of attention-grabbing components of our profession, but you're not just interested in sports medicine. You kind of live sports medicine. You're an athlete, completed Ironman, triathlon, all kinds of different stuff. You've been past president of the American Association of Podiatric Sports Medicine. Why don't you tell people who don't know the role of the AAPSM and what the purpose of it is?
Yeah, great question. And it's something that really has been, we get a little bit of sports medicine in school, in training, and it's not, it's not something that's really taught at all the schools now. At least most of the schools do have a sports medicine semester anyway. Mm-hmm. So you kind of have to go outside of your typical training to go to a sports medicine meeting or read a sports medicine journal or what have you. But I got involved when I was down in Miami. One of my attendings, a guy named Jim Lucido, who was Dr. Lucido is still one of the professors at Barry, a mentor to me, as well as Dr. Kashik. But anyway, he was involved with the American Academy of Podiatric Sports Medicine. I started volunteering, wrote journal articles. We had a newsletter, and every month I'd write a highlight from a non-podiatry sports medicine journal. It was related to foot and ankle, and then one thing led to another. I spent 7 years on the board of AAPSM and really opened the door in a number of ways, not only traveling and lecturing and meeting really interesting people along the way, but making connections with sports medicine and seeing kind of some of the legends in sports medicine, which led me to a step beyond AAPSM is the American College of Sports Medicine, which is kind of our umbrella organization. And I would highly recommend, if anyone's interested in sports medicine, beyond AAPSM is a great organization, but it's all podiatry, foot and ankle related. So if you really want a full team physician, PhD researchers, athletic trainers, anyone that has any contact with an athlete typically is an ACSM member. And I went on to become a fellow of ACSM and really met a lot of, and still some of my mentors today that were podiatry sports medicine practitioners. Actually, when I was president of AAPSM, the ACSM president was a doctor named Bob Salas. Dr. Salas is a primary care sports medicine doctor in Los Angeles, but he started at the time a program called Exercises Medicine, which is trademarked. Ironically, I was asked to speak next month at our APMA national meeting in Dallas on exercises medicine. So it kind of goes
Hmm,
full circle. But
that's
contacts
cool.
like that, meeting and knowing people in different specialties was really and continues to be one of the things I really look forward to because you're getting input from people that don't do just podiatry and they see things from different ways. And I've picked up a whole bunch of different things from that as well.
Yeah, absolutely. I think that's interesting, and I have a interest in sports medicine as well. So we're definitely going to circle back to that. We're also joined by Maddy Werd, who is a fourth year student at Barry University, currently out on her externships. How are you doing tonight, Maddy?
I'm doing great. I currently was in surgeries this morning, and it's awesome. Each day, I think I've seen something new and gotten to learn one thing more, and I've just continued to get to learn more. I've really enjoyed it, and especially finally, being hands-on after studying the books for so many years.
Yeah, it's a waterfall of information. What's interesting about fourth years, you go out on these externships and you show up on day one. And it's a little intimidating because you don't know anybody, you don't know where to go, you don't know where the OR lounge is. How do I get scrubs? And then as soon as you start to hit your stride and you feel super comfortable, you leave and you got to
Yep,
start over day one. Start it
yeah, you
over.
each Sunday, the night before a new month, I get those Sunday jitters and I'm like,
Mhm.
there's the nerves kicking in. But yeah, no, you're right. The residents have all the residents are so welcoming and everyone really just wants at the end of the day to teach you because one day you're going to be that resident teaching another student. But the jitters are real, but at the end of the day, you really learn a lot.
It makes you branch out a little bit. It makes you kind of come out of your comfort zone. I think it's easy as a student to get in your comfort zone at your school. You're comfortable with all your friends are there. You live wherever you live and it's all comfortable. And then you get out, you have to get out of your comfort zone when you get out on fourth year. But I've said it before, I think it's really important for us to be able to do that because other specialties don't have the ability to spend time at the programs that they're potentially matching at, and that would be very strange to me. At least you get to show up and get an idea and get a feel for what the residency and the residents at that program are like. So what has surprised you the most about fourth year that you kind of weren't maybe ready for?
Honestly, I wouldn't say not ready, but to your point of, I've grown up in Florida, born and raised Lakeland, went to Florida State undergrad and
Hmm.
Barry, as you said. So I've really only lived in Florida. Getting to do these externships, though, it really has been a change, whether it's the externs or the residents. I'm like, "Oh, where are you from?" In my mind, expecting Florida, but they are from all around the state. So you're really getting to get training from people who have learned so many different things, and you're getting to kind of pick up on things that you would like to implement, things that you might not implement, things you want to learn more about. So that's really been something that has stuck out to me as an extern so far, and especially just to that point of really learning what you might want to implement in your future versus things that not as interested in and just having your own opinion on things now because you learn everything but now you're seeing it for yourself.
Yeah, I think that's important. So I've talked before about what externs should look for in a residency, or sorry, let me reverse that. We've talked before about residencies looking for an extern showing up early,
Hmm.
being prepared, reading the night before, understanding what surgeries are coming through. But what do you look for in a residency from your point of view?
So that's a great question because not only are you showing up as almost a month long job interview, but at the same time, that program needs to show who they are to you. So that's something that I've really been trying to take into account, not only to be my best self and really enjoy the program, but what I look for when I'm there is how are the residents? What is their dynamic like? Do they work together? Do they have each other's back? Because you might be on call and scrubbed into a surgery and you can't make it, but you need your co-resident to have your back. Like, how is that dynamic? Versus also, how is the dynamic between the attendings? Are the residents getting to do the surgeries or are they just standing there not getting to do the surgeries? Like, how much hands-on are they getting to have? Another thing is how prepared I noticed that those residents are for the case. Really just to see the knowledge, especially a question that I like to ask is, the first year residents who are just now becoming second years, what are their numbers? How many cases have they gotten to scrub? What's the surgical volume at that program? Um, Another big thing is boards pass rates. I know they're allowed to take the in training exams.
Hmm.
So what is that program's pass rates? Those
Yeah.
are all things that, I've been learning, and you learn as you go. You kind of learn what to look for. My first program till now, I've picked up on a few more key things to kind of keep in mind. And lastly, how many hospitals are they taking call at? Are you going to be doing lots of driving at these programs?
Hmm.
And especially not like you want to get the best training, but while you're on these externships, I found it's very important to also get to explore the area
Hmm.
because, outside of the hospital, when you do get that free time, like you want to be in an environment where you can see yourself enjoying it and feeling comfortable and seeing yourself living there for 3 years, because that is 3 busy, important, stressful, but fun years of your life.
Yeah, I think those are all good points. When it comes time to pick your externships, I remember it was a long time ago now, getting old, but I remember thinking, well, I don't want to put my number one program first, but I also don't want to put my number one program last because that's kind of, you have to apply for interviews and all that stuff, and you
Interviews.
don't want to be too late in the game. And they're like, who's this person? We're not giving them an interview. That's at least what I thought. I don't know that that actually happens. But what was your thought process for trying to put the order of which externships you were most interested in? Did you think about that, or did you just kind of say, I'll take what I can get and we'll figure it out later?
Yeah, so I think there were definitely a few factors that played into it. First, though, I want to say it is very difficult because you choose these externships the end of August of your third year,
Uh-huh.
and you don't start them until, at least for Barry, we start in May. We have May until December. We take 1 month off, and we work at a Barry clinic 1 month. So we have 6 externships.
Yeah.
Um, but something that I've learned with podiatry is externships is really word of mouth. Um, it's getting the resources on this. There is a survey, an externship survey that all of the past externs fill out that you can kind of gather some information from. But after you figure out where you're going, as you asked, the month placement, um, some people will say it matters. Some people will say it doesn't matter. People say, especially in July, that's when the new residents start. So that month can make or break you. You could show up to a program and be super helpful and really leave a lasting impression on that first year resident, versus that first year resident might be so overwhelmed that they might not remember you in July. So there's these little key things that people tell you to remember, and
Yeah.
putting, your first externship, you might not be as prepared as you are on your last externship, or you might not have had as many of the or the questions that they ask you as compared to the last. So I at the end of the day, I think every program that I'm going to, I was very interested in. So no matter when I would be there, I think I kind of thought to myself, I'm just going to show up and be myself and study and work hard. And hopefully the month doesn't matter. But
Mhm.
yes, people do take that into account when they choose.
Yeah, after having gone through it and been on the other side of it, I don't think it matters that much. If someone's good, they're going to be memorable. And if they're horrible, they're also very memorable. So you remember the
Well,
good and the bad?
yep. I will say my first month, a lot of the residents actually that are there were like, this was actually my first month as well, whenever I was an extern. So, and I was nervous going into it, like, is that going to matter? But it really didn't at the end of the day. If you show
Yeah.
up and you work hard, you're
Yeah.
going to do well.
The one thing that maybe does matter is if you go to an externship in May or June and you love the whatever resident, I can't do the math, but if you love the third year, obviously they're going to be gone in a month. But
Yep.
if you love the second year, by the time you get there, they'll also be gone. So it's like you have to be careful of which residents you really, really like at what month, because you have to fast forward it and figure out, oh, well, they're not going to be there. So that
Well,
does
that's
play a role a little
something.
bit.
Yeah, to your question earlier of what do you look for when you're externing, that is another thing. These first years, um, now, I guess, starting in July, how will
Mhm.
I work with those residents? And everyone has been great, but that definitely is something to think about. And especially, I would give advice to students, though, if you do go in those earlier months where maybe you haven't even met the first year incoming residents because July hasn't started, to go back and visit and get to know those residents and introduce yourself to them so they know who you are. Because at the end of the day, that's who you would be working with.
Yeah. I went to a program and there was a third year I absolutely hated. He was the worst. But all I thought was, he'll be gone.
They'll be gone.
What can you do? Oh, well, he'll be
At the
gone.
end of the day, they're gone. But then you go to a program and then you love the third year and then you're like, oh no, they're gone.
Yeah. And then you're like, I hate that guy. He'll be gone. And then he gets hired on to be an attending. And you're like,
And you're
that
like, oh my
backfired.
gosh, torture.
All right, Dr. Werd, back to you. So you serve as a team physician, and obviously you're passionate with sports medicine. So what's it like serving as either a consultant or a team physician for our local sports teams down there? Obviously, you're dealing with the athlete, but you're also dealing with the parents, which in my experience could sometimes be more annoying, might be too strong, but it can be a little bit annoying in terms of how high maintenance they are. So how do you deal with the patients that are also attached to difficult parents?
Boy, how long is this podcast for?
We got all night.
Yeah. So, and that's part of it. And part of sports medicine is obviously treating the athlete, and depending on what level you're at. So we see everything from professional. We consult for local Major League Baseball team in town. Detroit Tigers are here, so we see some of their players, as well as Division II, one of the top sports Division II programs in the country, Florida Southern College, Southeastern University, and then all the local high schools. But you're right, some of the more challenging, not challenging patients, but challenging parents of patients can definitely come into play. And I've got a pediatric sports medicine talk that I give, and a lot of these injuries we're seeing now are athletes that are 7, 8, 9, 10 years old that play one sport the entire year, one position, because they're not necessarily enjoying that, but their parents or coaches are guiding them to try to become a better athlete for the team by taking private lessons and doing this and doing that. But this, for example, I had I think she was 11 or 10 or 11-year-old soccer player that did travel ball, school ball, private lessons, and she came in with heel pain. Your typical, and this is where sports medicine I think differs from someone that may not do sports medicine. Your typical heel pain, Sever's disease patient, but it just didn't seem quite right. And long story short, this girl ended up she had a calcaneal stress fracture. And, a 10 or 11-year-old, 10, 15, 20 years ago, you didn't see that. And basically just overuse. Growth plate was fine, but and then trying to explain to the parents that maybe it's better off if she goes out and plays another sport or takes time off instead of 10, 11, 12 months a year playing soccer or doing whatever the activity is. So it is a little delicate in that aspect. Along the professional athlete, I routinely have obviously the athlete, but the athletic trainer for the team is often accompanying because it's someone that needs to get back quickly. And depending on what level, and I've had a few athletes that have been here in the treatment room with an only athletic trainer, parent, agent, and that's an interesting discussion when you're not used to having all these people. We've kind of got used to it, and you basically have to be objective, and it's really what's in the best interest of the patient first, and the chips kind of fall where they may otherwise.
I think,
but definitely dynamics that you don't get with some other types of patient clientele.
Yeah, I think it's hard because you know what the athlete wants to hear, but sometimes the news that you have to give is not what they want to hear. They want to hear that, oh yeah, you're fine, you can go back to play tomorrow. But sometimes that's not the case. And how you deliver that news can sometimes be very difficult. And you have those difficult conversations. And then ultimately you're trying to explain to them, well, I'm trying to tell you what's best for you. Could you go back and play tomorrow? Maybe. Could you make it a lot worse? Maybe. You're rolling the dice there. And so those conversations can be very difficult with some of these, especially the higher the level of the athlete, if they're expecting or currently are professional, which means that's their livelihood. I need to get back. Some of these younger people are just, I do it for fun. Okay, great. But some of these people are depending on their body to be their livelihood. And those conversations can be very difficult.
Yeah, no doubt. And just along the the kids getting pushed too hard to play. This was a whole symposium at an ACSM, American College of Sports Medicine meeting I was at a few years ago, and
Hmm.
one of the other team docs just said, you know what, when he kind of saw athlete getting pushed further than they should, he would remove the parent from the treatment room. He'd have a nurse or another personnel come into the room with them. But once the parent was out of the room, he would be able to communicate with the a little more clearly and basically asked, are you enjoying what you're doing? Do you like it? Are there any other issues? And
Yeah.
7 or 8 times out of 10, that's when the patient said, "Oh, I hate this. I don't want to do it." And some they would not say in front of the parent. So,
Yeah.
um,
That's really
not bad,
tough.
a bad thing. So.
So, if you have different types of athletes, do you find that it's important to change your treatment based on the sport? Example
Mm.
being, if you have a gymnast, they're going to be subjected to a lot different forces than, say, a soccer player who's doing a lot more cutting than hard landing. Do you find yourself changing your treatment recommendations based specifically on the sport?
Well, yes, and a step further would be not only the sport, but where they are within their sport. Meaning, are they mid-season? Are they end of the season? Are they a senior? I've got a
Hmm.
girl now that she's a college soccer player. She's got one more year to go, and she's just about to start what she wants to play her final year. Uh, so we're trying to manage that, but that's a different discussion than if she was at the end of the year and the team had a losing record and they weren't going to playoffs, you're
Right.
different. Or in the off season and she needed some elective surgery, that would be the option. But yeah, a gymnast versus a soccer player versus a basketballer, what have you, the approach is definitely different. The gymnasts, they're not wearing shoes. Can't really do a whole lot of issues if you were looking at doing an orthotic or shoe modification or what have you. But yeah, I mean, there's definitely some variability between sports, and I think that's one thing that the more active you are as a physician, meaning, the old saying, if you walk the walk, you talk the talk, getting involved and understanding what the nuances are for gymnastics. Cheer is a big thing here. Maddie was a big
Hmm.
cheerleader back in the day. Base
Hmm.
is better than the flyer, which I never really knew about that. But although the base, you get the
Taught
flyer
him some
landing,
new things.
you get some concussions and things like that. But just understanding the different positions and ballet, knowing different ballet positions, what they're going to be doing
Hmm.
and what they should or shouldn't be doing is a big part of it. So I think the more educated you are, not only about the sport, but the potential movements of the sport or within the sport. And the other thing we try to do, you can't do it everybody, but if you can see that athlete in their sport during the sport, meaning baseball, will go out to the baseball stadium and see what happens when they're turning first base or what have you, or get into the dance studio where it's not practical in all senses, but in the best case scenario, if you're able to see, because sometimes sitting in a chair and pushing here or there doesn't really give you as much information as actually seeing what's happening or what they can or can't do or what the restrictions are.
Yeah, my sister was a dancer, so if I ever get a young girl who's a dancer, I kind of blow their mind. I'm like, "What are we into? Tap, jazz, lyrical? What are we
Right.
doing?" And they're like, "What? How do you know all about these?" I'm like, "I had to sit through my fair share of recitals. I might have been on my Game Boy, but I was still kind of watching." So it helps when
But
you
that
can under.
Yeah,
Go ahead.
so that dance patient you have is all right. So now her ears perked up. She's like, all right, this guy actually knows a little bit, and more
Right.
likely would listen to whatever you're going to recommend. So
Yeah, exactly. And that's kind of the benefit of, you don't have to be an athlete in every single sport, but at least if you understand the sport, you have a better understanding of the biomechanics that go into the activities that they're going to be doing and how to help them. I think it is important to understand exactly what they are going to be doing, and the demands that they're putting on their body may be different. So I think that's an interesting curveball part of sports medicine.
I will
yeah,
say, as a student, Dr. Lucido at Barry is our sports medicine teacher, and he teaches us keywords in a lot of the different sports. In ballet, he has us know releve, plie. They're exactly what to call the cleats. Like he teaches
Hmm.
those keywords because he tells you, he's like, it matters when you're talking to these patients. They'll notice that you really do
For sure.
you have a greater understanding.
Absolutely. Dr. Word, on your CV, you have listed that a Guinness Book of World Records. Is that true, or is that just fluff and you're trying to sound cooler?
Yeah, that's just to catch your attention. And no, actually, it's a real thing. I've done a whole bunch of things, as you can see,
Yeah.
outside of podiatry, and that's one thing I really enjoy. I've kind of looked at doing things that are hard over the years, and I try to pick something once a year, once or twice a year, to pick a hard thing to do.
Hmm.
I think they call it misogi. It's a Japanese term that you basically pick one thing a year. And I just recently found out there's two criteria on a misogi. One is you've got a 50-50 chance on finishing it. That's number one. And number two is you can't die. So, um, but, but
It's
in
a
some of
downside if, yeah.
the sports psychologists, some of them will challenge their professional athletes to do a misogi.
Yeah.
Anyway,
So what is your record?
but yeah, so the record had to do with cycling, and I had a patient of mine who was a spin cycling instructor. She had heel pain, plantar fasciitis. We kind of got her better, and she knew I was a cyclist that did a lot of cycling, and she had lined up it took her, I think, a year or two to get her lined up, but it was the longest consecutive spin class in the world. And the record at the time, I believe, was 20 some hours. They needed 10 people. You had to follow the instructor. There was four judges. They changed every 4 hours. There was video. It was a big production. And all 10 people in the class had to follow exactly what the instructor did for as long as you could do it. This was my first spin class ever. I'd never done a spin class. First and last, I joke about it now. Anyway, at Sunday at 12:30 in the afternoon, so 24 hours, 30 minutes later, we finished. And at the time, we didn't know if it was legitimate, because you had to submit all the videos and the judges and the Guinness, and they're real strict about it. So anyway, I'm still have it here. I got the official certificate. I don't know if you can see it, but it's embossed, and it's so I was officially in the Guinness Book of World Records.
That's awesome. Congratulations.
Yeah, it was pretty exciting. So I haven't done a spin class since then.
Well, why would you? You did the number one spin class that no one could touch. So why do another one? It won't be as good as that one.
No, that's, I've done Ironman, I did the Hawaiian Ironman, and since then it's, check that box, and on to the next thing.
That's awesome. We're talking about sports and athletes. Maddy, you were recently invited to speak at the Florida Podiatric Medical Association meeting down in Florida, obviously, on bone stress injuries in athletes. Let's talk about that for a little bit.
Yeah, so that was an awesome opportunity. I got asked by FPMA as well as the AAPSM. Through the American Podiatric Medical Student Association, I am the delegate for my class at Barry. Being a delegate, you can run for liaison positions. We never had the AAPSM liaison position, so whenever I attended my first House of Delegates, I immediately kind of jumped on, let's get this created. It's one of the third largest clubs nationally, and the amount of students that are interested in podiatry because they hear sports medicine, I really wanted to raise more awareness about that. So created, established, installed, and became the first AAPSM student liaison. And it's been going so well. And Dr. Laird, the current president, reached out asking me to speak at the Florida conference. Doing that was a great opportunity. I not only got to speak on a stage to, I want to say, around 100 doctors as a student, but I got to practice.
That's tough. It's intimidating.
It was. I was very excited. I really enjoy getting to meet and network and kind of explore the field. But before I got on that stage, I was nervous, but it went well. And also the background research I got to do along with the process. Just getting to really understand bone stress injuries more myself. They are so common in athletes. I want to say it was over 20% of sports med visits to podiatry offices are bone stress injuries. And even just working clinics myself as a third year and now fourth year, I've actually diagnosed quite a few bone stress injuries. So it was a good topic that I felt as a student I could present on. And while bone stress injuries the history is kind of stayed the same, it's something that some podiatrists might not see every day. So it was informative to a lot of people, I believe. But yeah, so that was an awesome opportunity, hopefully opening up some more doors in the future, and I hope to lecture again.
Yeah, for sure. I remember the first time you get up and you lecture in front of an audience, you're number one, you're scared, your adrenaline is pumping, your hands are a little shaky, you feel like your voice is a little shaky.
Speakers needing water mid lecture. I found that out the hard way. I was always like,
Mhm.
throat goes completely dry after a few minutes.
Yeah,
So definitely it taught me a lot, not only just prepare a lecture and go speak with a lecture, but have a water bottle on hand. No,
yeah.
things might not always go the way they're as planned. So I definitely learned a lot while being up on that stage, but I really enjoyed it.
It's almost impossible also to not have imposter syndrome. There's always something in the back of your mind like, why would these people want to hear from me? And then you give the lecture, and then people are like, oh, that was great. I didn't know about this and that and the other. And they're like, oh, okay, well, I guess maybe I did teach you something. But there's always that something in the back of your mind like, doesn't everyone know this? If I know this, definitely everyone else knows this.
Well, I kind of expected whenever I went up to the stage, everyone would walk out because it was a student on the track. But no, honestly, there were a lot of podiatrists in the room and they were even taking pictures of the lecture slides, which made me happy that they were gaining information
Uh-huh.
from it. Because I know I called my dad the week before, Dr. Laird, Dr. Mendezoon, and I
Mhm.
was just like, well, practicing podiatrists learned something from this because to me, I was like, I'm giving a lecture on bone stress injuries. It's not like there's some new advancement in the field. I mean, you can diagnose an office with ultrasound, like there's some other ways to treat it, but I really wanted to make sure that podiatrists would gain something from it, and I hope I was successful in that.
Oh, I'm sure you were, but it's still an intimidating venture. And then you do it again, and you're a little less intimidated, and you're a little less intimidated. Then you get a little cocky. You're like, yeah, I'm pretty good at
Well,
this.
even after the fact, like I feel like the rest of the weekend, I was like, did that go well? Like I was still in my head the rest of the weekend.
Oh yeah,
Yeah, I didn't expect it to be like that, but I'm actually going to be presenting on bone stress injuries in athletes for the virtual Ohio seminar as well.
nice.
Dr. Mendezian is hosting. So,
Yeah,
yeah.
that's awesome. So, I mean, what did you take away from that the most? Because bone stress injuries are tricky. Usually there's obviously an overuse component, and certain age groups are more predisposed to bone stress injuries, whether it be younger athletes going through puberty that we are all aware of, or kind of a middle-aged population that seems to still, try to train for a marathon out of the blue, and then all of a sudden their heel hurts or something like that. So what were some of the main things that you kind of took away from that, educating yourself and then educating others about that topic?
Yeah, so I tried in mine since I was on the sports med track to focus specifically on athletes. I have always been a runner. I did cross country, I did track. I also played soccer, tennis, a bunch of different things, and I am a female. So I learned actually some of the top sports for these sports medicine injuries were specifically running long distance, as well as gymnastics and basketball. In all of these sports, females were 2 times more likely than males to develop bone stress injuries. And
Mhm.
that was something that I felt we didn't learn. We touched on bone stress injuries in school, but we really didn't get to dive deep into it. And getting to learn the female triad, that was something that as a female myself, some of those triad symptoms are things that I've experienced and thankfully I've never had bone stress injury, but it's
Yeah.
things that I really was able to educate myself on and the running scenarios as well as females, as well as just learning or just knowing, if a patient comes in and they've kind of told me they've changed up their workout routines recently, that they've been wearing different shoes and I had a
Mhm.
patient who was a running coach as well as she started doing more CrossFit and changing her
Mhm.
shoes up and she had a
Mhm.
calcaneal stress fracture. So it was just learning those different changes in the micromotion and repetitiveness and sports specifically to look at
Yeah.
is something I really took away.
Absolutely. Dr. Word, have you had any injuries that have limited your, whatever it may be, whatever you're training for? Have you ever had any significant injuries that set you back?
That's almost a daily question I get in the office,
Yeah.
doing as much as I do.
Yeah.
Major, no. Plenty of little minor things that I've been fortunate enough to kind of know what is coming. I think I've probably had a few pre-navicular stress fracture injuries that I've
Hmm.
avoided by changing. So I back in the late 90s, I ran probably 60, 70, 80 miles a week. I did some marathons. I was training for Boston and actually ended up having just from doing speed work in hills to train about 6 weeks out from Boston. I had a really a pretty bad IT band issue,
Hmm.
which caused me I literally couldn't go past 8 miles before I had to stop, which is when I started to get in the pool to keep training. And I got on the bike and ended up, I did the Boston, finished fine. But after that, a few weeks, I did my first triathlon and realized the benefits of cross training to the
Hmm.
point where I think I've got over 200, not Ironman, but regular distance or sprint distance triathlons, including 4 full Ironman distances.
Wow.
And I think the cross training part of it, what that's taught me is you don't have to do one thing, and you're actually better off doing multiple things over a period of time because you're stressing different, not only physically, but I found even mentally. You kind of get in a rut when all you're doing is running all the time, or if all you do is swim or what have you. So by doing multiple sports, you keep engaged a little bit more, and you actually look forward after you've been doing something else. Um, to go back and do each of the individual sports. I have actually operated on myself one time.
What?
Minor, but
Wait.
all surgeries are minor, but a little ingrown. I had a little paronychia that
Oh, I think I
numbed.
walked in on that. I was like, what are you doing to your toe?
So I numbed my own toe and took out my own paronychia at the time. I think it was a week or so before some event I was doing, and luckily I healed up without too many problems.
I
My wa-
actually,
yeah, go ahead.
oh, I was going to say, I was very fortunate. I no major injuries either, but I had sprained my ankle in a high school soccer game. And thankfully, I know some people, but I was able to have a quicker recovery, just being able to have my dressings changed more often, get into physical therapy, and do the cross training that he mentioned. One thing specifically that he had me doing that I feel like really benefited me and helped me get back because I had track season starting up soon was the Alter G treadmill.
Hmm.
So that cross training as well as an elliptico, it's pretty much an elliptical with bike wheels. So both of those got me back, I think, within 3.5 weeks from a grade 2, grade 3 ankle sprain. Um, Started back up cross country immediately, or track, I think it was.
Yeah, that's awesome. My wife is a runner. She's a runner and I'm a sitter. And so she's run a 50-mile race before. She's done
Oh
some
wow,
marathons and
she
done a
does
50-mile
ultras.
race. Yeah, once. And I told her never again because it was horrible on me, not on her.
It's
It was horrible on me.
because you had to sit there for how many hours?
It started at midnight. I had to wake up, take her to the starting line, and then go back to sleep and then wake up. It was horrible. And I always tell her if she gets like an IT band issue, I said, you know how you don't get hurt? You sit on the couch.
Right?
She doesn't find that amusing. So let's
Good.
talk about some different sports injuries and how we can treat them. So let's kind of do, it doesn't have to be rapid fire, but let's say you get someone that comes in with a turf toe injury. What are your kind of things that you're thinking about in terms of diagnosing and trying to rehab? Because turf toe can be a very difficult injury for people.
Maddie, I'll take this one. Yeah,
Either
Go
one.
right ahead.
yeah, no doubt that's potentially career ending, and it has been career ending for a number of professional athletes. So anytime there's a syndrome, turf toe syndrome, shin pain, these things that are not diagnostic, but they just kind of tell you what's going on in a region.
Mm-hmm.
And I think that is where an astute sports medicine practitioner, he kind of sets himself apart from someone that may just call it turf toe and say, go in the boot and do this or do that.
Mm-hmm.
So I think number one is coming up as quickly with an accurate diagnosis is going to be the key on what you do or how you treat it. Meaning, okay, so they jam their big toe joint. Is there a fractured sesamoid? Is there a tendon issue? Is there cartilage in the joint? Which means we're probably more likely to get more advanced diagnostic testing sooner than we would with the non-athlete.
Mm-hmm.
But and this is one thing where diagnostic ultrasound, if you're starting to use it or haven't used it much, like I said, like I mentioned before, I don't go through a day without probably using the 5 or 6 patients, if not more, for diagnostic purposes and other purposes as well. But so number one,
how did you learn to do the ultrasound? Are you self-taught? Did you do a course? How could people who are like, I don't know how to use ultrasound, how did you get to be comfortable with that?
yeah. So there's a definite learning curve. I'm going into probably 20 years of doing it. So over the time, obviously get better. But the initial, when I started doing it before anybody was really doing it. And some of that was through my experience at American ACSM, American College of Sports Medicine meetings, where some of the diagnosticians were doing shoulders and other things, and that's what initially kind of got me into doing it. They had a small little course that I did. It wasn't foot and ankle specific, but that kind of got me hands on feeling it, and then I met a few people that were doing it within podiatry, and as many meetings as I've gone to, you start to see people that are doing it, and then they do lectures, and then I've ended up probably giving 30 or 40 lectures on musculoskeletal ultrasound and the benefits of it and how to do it. It's definitely a learning curve, and for someone that hasn't done it, just get your hands on. A lot of the meetings have a lecture workshop or something with ultrasound that I'd recommend. If not, go to, find a booth that has selling ultrasound. The reps are very knowledgeable, and you can start. That's a good start to play around with.
Hmm.
The bigger tendons, the easier it is. Achilles is very easy to see. So I think number one is you just got to start. But number two, and this is something I'd like from the get go. What are you looking at? You're looking at cross sectional anatomy. Okay, so a lot of things we do comes back to what's the anatomy, and it really causes you to refresh your if you're not up on what your anatomic structures are, you know put the ultrasound on your leg and go around and move the big toe and see where the FHL, invert, evert, supinate, pronate. You can see where the posterior tib tendon is, and so
Hmm.
forth. So it really causes you to brush up on your cross sectional anatomy, which some people
I
like,
will
some don't, but even better.
I will say I've learned since being on my externships that not all schools actually are teaching or, doing labs with imaging. And that's something that Barry has taught us. We had with Dr. Armstrong, he just retired this year, actually. While on our third year, we have a clinical rotation with him specifically where we learn ultrasound and we have a few labs where we just practice it. We even practice giving injections with it. We do like the key anatomical structures in the foot and the leg, as well as x-rays. And the x-rays are very beneficial. Working at some of the clinics on externships is we're taking the x-rays ourselves instead of the MAs helping out the doctors. So that's something that Barry's done very well, is trying to teach us the ultrasound, reading an MRI, reading a CT, how to read an x-ray, those capabilities, as well as taking the x-rays and ultrasounds for ourselves.
So I would say just and learning it. When do you do it, or what do you do it for? Start with easy things that you know how to do and you're comfortable with. It's really you having like eyes under the skin. You can kind of see under the skin. Um, you know, it, I would say anytime you order an MRI, especially for any soft tissue, before you order the MRI, and if you have access to an ultrasound, put the ultrasound on and see if you can predict what the MRI is going to show you. Because a lot of
Hmm.
times, the advantage of the ultrasound over the MRI, obviously, the resolution is a little bit different in how you see it. It doesn't penetrate bone, so you can't see within the bone, but you can see everything around it. But um, the big benefit is you can move things in real time with the ultrasound, meaning
Sure.
you got a posterior tib or peroneal tendon, you're not sure what's going on. Put on a tendon, you can invert, evert, and you can see, or you put the ultrasound on the peroneus longus or brevis muscle belly in the leg and move distally. And if it's a rupture, obviously you're going to see different things. So that's one advantage over the MRI. But it's a learning curve. I'm not going to say it's easy, but it's like an X-ray. Now it's pretty much a daily thing in practice, and I couldn't imagine not having diagnostic ultrasound. And now the handheld units, which are a handheld unit that'll go iPad or even your iPhone. You can look at the unit with similar resolution to when I started doing this 20 years ago, and you can take that into the field or on the practice field or to a game. You can have an ultrasound on the sideline, which is pretty amazing technology.
That's interesting. I didn't even think about that. So yeah, obviously I think it's an underutilized skill in our profession. I think some people who do it and are very good at it, they have an advantage over the people who don't utilize that and they have to wait for MRI. Sometimes you could see clear as day. Okay, yep, your Achilles is ruptured. I don't need an MRI. I don't need an ultrasound. I can tell your Achilles tendon is ruptured. But you get into the smaller structures, the plantar plate, the turf toe, Liz Frank, things like that, that are very difficult and subtle injuries, and you may not be able to 100% tell with ultrasound what's going on, but sometimes you can get an idea and head in the right direction with the ultrasound. So I think that's a very useful skill for people to be able to learn.
No doubt. And so, what's the worst case? So, you look at someone with an ultrasound, you're not sure. I send them out for the MRI.
Right.
In some insurance companies now, we've got one that requires a musculoskeletal ultrasound before they approve an MRI. So,
Absolutely.
being able to do that in the office instead of sending it to send it to a musculoskeletal radiologist makes a big deal. And
For
the
sure.
one last point on that. And I've been doing this for 15 plus years. Runner comes in, swollen dorsal foot. You're suspecting mat stress fracture. X-ray doesn't really show anything. If it just happened, what's your next step? You're probably going to send for an MRI.
Hmm.
I can contend, and I've seen enough of these where you suspect a stress fracture, and I've had a few of these the same day that they went out for a long 20-mile run or whatever it was. Come in the office, ultrasound. Don't even take an X-ray. You don't need to. I can make that diagnosis and document it objectively. Um, there's a subperiosteal bleed that you'll see within hours of the stress fracture where X-ray is not going to pick up. And by the time you send it for the MR and they come back 3 days later, I can make that diagnosis. Not only make it, but 3, 6, 8 weeks later, I can have them come back and repeat the exact same ultrasound. And you can actually see where that subperiosteal bleed was. Now you can actually start to see the bridging of bone from the healing. So I would recommend if you have it and haven't thought about using it on a stress fracture, that's definitely a little pearl that we've been doing that long enough, and it seems like no one else really does that.
Yeah, that's really interesting. I want to talk about 3D printing orthotics. You mentioned you do 3D printing orthotics in your office. Tell me how that works.
Yeah, so we're probably 50 plus pairs in on doing this, and it's been out there. It's definitely on the front of the bell curve on implementing this in your practice. A good friend of mine, Paul Langer, practices in Minneapolis. He kind of got this up and running and living the fruits of his labor of actually figuring out how to do this. And there's
Hmm.
several companies that do it, but basically with the technology. So with my iPhone, you use the front facing camera. So you're using the facial recognition software, which is
Hmm.
amazing. It's really amazing. But you take a front facing scan of the foot, loaded position, subtalar neutral, however you want to do it, within an app on the phone. That image gets digitized into a printable file. That printable file is sent back, that's sent electronically. That printable file gets input into software where I can manipulate not only what the orthotic looks like on that foot, but if I want to do varus valgus, turf toe, Morton's extension, met pad, whatever you want to do, you can do that within software. And then that
Hmm.
software saves the image as the print file. And basically that print file gets sent to we now have 3D printers in the office, but I we'll send that printable file to the digital printer, and it's an additive versus subtractive. If that means anything, I'm learning a lot about 3D printing. Subtractive printing basically takes a block of plastic or whatever, and it carves out a additive takes a spool of basic filament, looks like it's a thick fishing wire. That
Hmm.
filament gets filled in, and that uses that to print the orthotic based on whatever you input in your software. So within anywhere from 2 to 4 hours, I can print the actual physical orthotic in my office versus casting or scanning and sending to a lab, and the lab has to make, and you get it back, and if it's not right, the other advantage is if you want to tweak it a little bit more, a little bit less, I tweak the software and I just reprint another orthotic, and
Hmm.
we've done that with obviously all the way up to the professional level, to heel pain or post-op patients. I just had a first MPJ fusion patient. I just print them a pair of orthotics with kind of a rigid first ray extension. I've been doing this almost 30 years, and actually one of the more things I look forward to is how exciting this is. I gave a lecture at SAM this year at our state conference back in January when I first started doing these, and probably 1,000 people. I asked how many people are 3D printing their orthotics, and a couple of hands raised up. And I made the comment that if I come back here in 5 years, I bet half the room is going to be raising their hands
Yeah.
doing it. Because once you get it down, and there's definitely nuances, same thing as a learning curve, but there's so many advantages to being able to do that, and the simplicity of it. Once you get everything up and running, and you can add top covers, you don't have to add top cover. You can put it under the current insert in their shoe. I got a perforated top cover I use on a lot of the athletes. If it's a tighter shoe, all you do is print the orthotic, and you can make it smaller, narrower. So all they do is put it under their cleat, under their existing insert that's in the cleat. So I mean, that's a whole nother lecture that at some point I'll do a whole lecture on 3D printing orthotics.
How much does that cost you? Not how much do you charge the patient, but how much does each pair cost you to print?
Yeah. So whatever you pay your orthotic lab, whatever it is, however many you do, that goes away instantly.
Right.
So number one, you gotta buy the setup. You gotta buy the printer.
Sure. The
You
upfront costs.
upfront is, I mean, and it's reasonable. I've been looking at this for 3 or 4 years, and there was a system we were about to buy years ago. It was $20,000-$30,000, and it's significantly less than that. Anyway, so once you get it all up to speed, we pay to convert the file into a digital printable file, which is $20 per digital file. Once we get that file back, we can make 100 changes on it. Once we have a printable file, that can be manipulated however you want. And then number two, the only other cost is the filament. It's a big spool of filament. You can probably get, I don't know, 30 pairs out of one thing of filament. So and it depends on if it's a 300-pound lineman or a ballerina or somebody that's smaller. But I think on average, less than $10, if even less than that. So you're $30 in for printing your own orthotic. And like we've had some of these at a base Tigers player that he was heading out of town, and he needed a orthotic the next day, and I had him, brought him in the morning, scanned them, printed it that afternoon. I put a top cover on. Actually printed two different pair. One harder, one a little bit softer. And the next day, I mean, you're not going to be able to do that with a lab. That's why I said that this is kind of the future. I think the future of orthotics, and with sports medicine, it's got a whole lot of advantage.
For sure. That's awesome. Maddy, what advice do you have for fourth years? Not to your other fourth years right now, but people younger than you. What advice do you have for younger people about fourth year?
I would say really enjoy it. As much as you'll be nervous, showing up to these programs, and you want to impress the program, also really enjoy it because it's making those connections and being yourself, but really trying to learn a lot. And as much as you want to push yourself to study, and you should, try to explore the areas where your externships are, because again, it's where you'll be living for those 3 years. So not having a little bit of stress about the program, but really just try to be in the moment and take everything in, because at the same time, you're not just trying to see where you would like to go for your residency, but your training's starting. So you're already starting to learn, and that's where your hands-on experience is beginning. I know my dad could probably even say, he was at his different, or both of you guys were both at your different externship programs, and I'm sure you can remember a few things that you learned from those programs that you didn't end up doing residency at, but you're going to gain some sort of knowledge every single day.
I think that's a really good piece of advice that sometimes gets lost in the shuffle, and that you're so focused on, do I like it here? Do they like me? You get so caught up in the shuffle that you sometimes lose the point of view, or you lose sight of the fact that you are learning. And it is somewhat selfish in that they can teach you things. And like you said, you pick up things from, even though you could go to there were programs I went to, I thought, this is horrible, I will never end up here. But that doesn't mean you can't still selfishly take something away from that and learn from whoever is there and from residents while you're there. I think that's a great piece of advice.
That, and, some programs, they'll pimp, everyone uses the term pimp. They'll pimp more than other programs, but if you get it wrong, that's okay. At the end of the day, when you miss a question, you probably won't ever forget the answer.
True. And I think it's more Sometimes you don't realize it. They don't really care if you get it right or wrong. Number one, if they're good residents or good attendees, they just want to teach you. They don't really
Mm-hmm.
care if you get it right or
Yep.
get it wrong. But they are judging you based on how you respond to that. There are certain students and when I was in, a resident, then younger residents who would not ever say, I don't know. And it drove me nuts. Like, just say you don't know. I could tell you don't know because you're not telling me the answer. But they would not say I don't know. They would tell me some other, oh, I know this. I'm like, I don't care about that. Don't tell me that. So I think it is important how you respond to the question and say, I don't know that,
Yep.
but I'm going to look that up and I will not forget it.
I strongly agree with that because especially this brings me back. I was an anatomy TA my second year for the first year students. And if a student asks me a question, I'm not going to tell them the wrong answer. I would say, let me check and get back to you. So same thing with externships. A lot of the programs, they'll tell you straight up, they'll say, don't guess. If you don't know it, I don't like guessing. And you tell them, I'm going to look it up and I'll get back to you. And even if it's while you're turning the patient over after the case and you look it up on your phone and you go and tell the resident after they're done dictating, like you can do as simple as that, or you could do as simple as emailing the residents an article. So that is great advice. And that is some advice that I have in terms of that. Don't guess because they'll know you're guessing. And it's sometimes better to say, let me look it up.
We have one of our professors at the school that works with my wife. My wife's too nice. She doesn't do this. But there's another professor there that if you get something wrong, he won't tell you you're wrong. He'll just keep asking you more and more questions and letting you go down this path, this deep, dark pathway of incorrect answers. And you don't really realize what's happening, but it's very uncomfortable to watch.
Well, what they do now is you'll get it right, but then they'll say, are you sure? Are you sure? And then you're like, am I sure? And then they'll go down the path of, even if you're right and you stick with your answer, they're going to deep dive. But also to that point, I know some students might be afraid to ask some questions because, they'll dig themselves in a can of worms. And I've done that to myself. But at the end of the day, I'm like, but I actually want to know. And every time I'll ask questions, they'll be like, you're going to dig yourself in a can of worms. I'm like, that's okay. Because at the end of the day, I'm going to figure out the answer to my questions and I'm going to learn something from this. So don't be afraid to ask questions. And if you don't know it, if they rebound the question back to you, say you'll look it up.
For sure.
Matt, you've heard that once or twice I may have told her about asking questions, which we always encourage.
I bet you I can say what you're about to say. It's better to feel stupid for a second than stupid for a lifetime.
Yeah. So if you ask a question, you feel stupid for 5 minutes. If you don't ask it, you feel stupid forever. So the point of that, ask questions and don't be afraid if it's silly, but you'll always remember. You'll never know if you don't ask it.
That's great advice.
You actually listen to your dad once in a while.
I actually repeat that to residents because they'll say, they're like, if you ask questions, then I'm like, you know what? I'd rather feel stupid right now than stupid forever.
That's awesome. That's great advice. Unless you're a student rotating through with me, don't ask me questions. You're driving me nuts. I'm just
You're
kidding.
Like, no questions over here.
Enough. No more questions. So I got to cut them off sometimes. Like, all right, you're out. You're out of questions. No more. I like well, we're done. Do
you rebound the questions back to them?
No, I hate when people do that.
We'll start doing it and they'll stop asking.
Yeah, there you go. It's a good tip. All right, I'm going to start doing something new. We have time. I'm calling them the Pod Patrol 8. They're 8 rapid fire questions for you guys. They're not hard. They're not quiz questions. They're just, you'll know the answer, I promise. So we'll go back and forth. Maybe we'll start with Maddy and then we'll switch to you, Dr. Werd, after each one. So we'll try to go rapid fire and see how we do. Number 1, coffee or soda?
Neither.
Okay.
Neither. Okay.
Before 40 soda, after 40 coffee.
All right.
Never had coffee before I was 40.
Number 2, custom inserts or off the shelf?
Custom.
It depends. Protocol, start with a over the counter. Most 80% of the time that works. If not, then custom.
All right. You're giving a TED talk tomorrow. What's your topic?
My topic would be
bone stress injuries in athletes.
Yep. That or surviving medical school.
Okay, good. Dr. Werd?
Find your Masogi.
Good.
And I'll give examples of it.
Sure. Number 4, bunion surgery, head or lapidus, head or base procedure? What do you believe in? Maybe you don't have enough information yet, Maddy, but what would you lean towards?
I know what his answer will be.
Okay. You want
He's
to
gonna
guess?
go with head.
Okay.
He's gonna say depending on the patient, but
Yeah, up in the air, but had still.
Okay. Best shoe brand to recommend to patients.
I've recently, and they're not for everybody, I know that, but I've been on the Ultra kick.
Okay.
The wide toe box, they used to be 0 drop. They do now have a 4mm drop. I have found them to be so comfortable. I haven't even needed to put orthotics in them. I actually just did my first marathon in them and find myself wearing them in the OR, walks every day. But I know some other patients who have been prescribed them by podiatrists as well, and they're a growing brand. I'm going with Ultra.
I've been recommending those too. So maybe they'll sponsor us. If you're listening, Ultra, sponsor us. Dr. Werd, what's your choice?
Yeah, I got it. Well, I got it. So I actually met Golden. We used to take at the running event every year, and I met a guy named Golden Harper that was there first time at Ultra. He had a box, and I wore his first pair, and I came home. Actually, then I came home with Hoka after this meeting, and everybody's making fun of me, but see where they are now. But whatever fits properly, and I send them to a running shoe store that will fit the patient into a shoe that fits them properly. There are some specific cases, but in general, I try not to recommend a specific shoe unless it's a specific pathology.
Sure. Number 6, what's your favorite surgical instrument? 15 blade, because you get to cut.
You know why I'm laughing. I wouldn't say as of right now, what do I use the most as a retractor as a student.
There you go.
But so I guess what I use the most at the moment is retractor or suture cutter scissors.
That's a good answer.
I mean, most use. You know what? I did a subtalar arthrodesis a couple days ago, and nothing like a lamina spreader to get in and expose joint. Yeah, we're
Crank it
exposing
open.
ulna or a first vein or space. So lamina spreader.
Yep. I love it. Worst OR playlist: country music, opera, or electronica? What would you least like to listen to?
Oh, I could say both opera or electronic.
Okay. Dr. Werd?
Yeah, probably opera. We a friend, orthopedic friend of mine, year round listens to Christmas music, and I would.
Oh,
He's in the room over. Actually, yeah. So no Christmas music.
I have to say to that point, my dad actually has a surgery playlist, and all of it relates to somehow something medicine, whether it's staying alive.
Yeah, I got to some kind of surgery related.
that's funny.
It's pretty entertaining, his playlist, actually.
I don't think I could do Christmas music in July. I could do Christmas music around Christmas, but that's it.
Yeah,
That's my study music once it hits like beginning November.
Solid. All right, last question. This will be hard for you, Maddy, but you can answer it. The one condition you never want to treat again.
Oh, I could answer that.
What do you got?
Severe lymphedema.
Oof, that's a good one. That's a really good one.
Yep. Those ER calls while being on call as a student and having to be the student to hold the leg while the resident has to dress those. And yep.
What do you got, Dr. Werd?
Well, I spent time at Cook County Hospital, the only public hospital in Chicago, and I still remember the patient 30 years ago that had dry frostbite gangrene, and we went to pull his boot off, and his foot came off with it. So next time I want to do that.
Luckily, at least you didn't have to amputate it.
You bill for that?
Yeah, right.
Did the amputation. That's awesome. All right, that wraps up Pod Patrol 8. Thanks for answering those questions.
That's great.
I think the one condition I would never want to treat again would be wait till you go on plastics and you'll learn about something called Fournier's gangrene. Anyone who doesn't know what Fournier's gangrene is, look it up and you will run the other way. Thank you guys so much for joining me tonight.
Awesome. Thank you so much for having us. This is
doing a great
awesome.
Job keep the pod long.
Yep, thank you. I appreciate it. So thank you guys so much, Dr. Matt Werd, and soon to be Dr. Maddy Werd. Keep doing a great job out there, guys. I really appreciate you spending some time with me tonight.
Yeah, thanks for having us, and thanks for doing this for the podiatry community too.
Absolutely. Thank you guys for joining us. Yep, thank you. Thanks for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Have a good one.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.